Hi, I'm Dr. Marianne Kate. Thank you for joining me. I'm really pleased that you're looking at this and are interested in the multidimensional inventory of dissociation, the short version. I think that this has so much potential in clinical settings at really getting to the heart of what is it that we're seeing. Is this dissociation? And what kind of dissociative disorder might this be? So this is really a broad-ranging instrument. It's easy to use, and I'm going to talk you through some of the basics of it.
There are 6 key points I'm going to focus on in this short presentation. The first is what exactly the MID-60 is and where it's come from. Then we're going to look at the types of dissociation that this instrument captures. Thirdly, we'll look at the difference between the MID-60 and the most commonly used instrument, the dissociative experiences scale, so you have an idea about which one is appropriate and when, and what the strengths of each are. Then I'm going to give you some tips on how we administer the MID-60 and what you need to be doing in working with your client. Then how you can interpret the data that you're getting from that and apply that clinically. And then finally, it's just looking at where can you access the materials so you can go ahead and use the MID-60 in your clinical practice. The MID-60 is a self-report measure, which means that it is the client's interpretation of the question and of their experience. That's not to say that they can't ask you a question if they get stuck, but really your answer is going to be the question means what it means to you. It's born out of the parent, which is the Multidimensional Inventory of Dissociation, which was created by Paul Dell. And this is an excellent instrument that is diagnostic and extremely rich in the information that it provides. Unfortunately, it is lengthy and so it doesn't tend to be used in clinical settings as much as it could be. And the other thing that happens is it's not really used in research either because of its length. So the MID-60 brings the key predictive factors from the MID's 12 scales to get the 60 items. We have done research on this, myself with Dr. Graham Jamieson, Dr. Martin Dorahy and Dr. Warwick Middleton. And what we've found is that it's got reliability and validity. So it's looking like a strong and suitable measure. The MID-60 captures a range of dissociative experiences, as well as some that aren't strictly just dissociative. So we look at the subjective awareness the person has of having alter personalities or self-states, however you'd like to refer to them. And this isn't just in the case of DID, where the person can switch into another personality. This is also those intrusions into consciousness that people, particularly with those with other specified dissociative disorder, that subclinical type DID, experience, where they may hear voices or they may say things and do things, and there's a level of awareness, even though they may not know why these angry words are flowing from their mouth, or why they're suddenly shying away from this person, or whatever it may be. The experience is quite alien to the person. They're really disconnected from what it is they're thinking, feeling, or doing. And this does include having these angry intrusions and the persecutory intrusions. These are more than people's inner critic, but we can see that for some people, they will see those persecutory intrusions in that way. So it does, within that, also capture those more normal experiences. They look at amnesia, and when we say amnesia, we need to be careful because it can be confused with dissociative amnesia. But that's not what we're talking about, whether it's looking at the dissociative experiences scale or the MID or the MID-60. This is really the amnesia that's specific to DID, where people have time loss about what has happened to and wake up to a situation that they are not aware of. They're finding things that tell a tale of what has happened, but they have no connection to the story that's gone. So it can also be these fugue states, and they're the types of amnesias that we're focusing on in this part of the questionnaire. There's also a lot of distress around people having memory problems and really not recalling much from the past or of their childhood. We look at the symptoms of derealization, so feeling that the self is not real or their surroundings, so depersonalization, the world around them is lacking reality. So we look at those kind of experiences, as well as trance, that absorption, and that disconnection. There are also some other items like flashbacks, which are very common in trauma survivors, including people with dissociation. So these are the really PTSD symptoms. We also look at self-confusion, not just being a little confused. This is this profound and chronic self-puzzlement that people with dissociation have. Then there are the body symptoms, these somatoform symptoms. For example, conversion blindness, where somebody suddenly can't see, or they can't hear, or they can't move. And psychogenic non-epileptic seizures. So these seizures that look like epilepsy, but they're not. They can be, a reenactment of specific traumas, or that all jumbled together. But it's not, there's no organic cause that's been found. The dissociative experiences scale, which was designed by Bernstein and Putnam in the mid-80s, has been used really widely. Its 28 items make it really easy to use, and it's excellent at picking up dissociative identity disorder and the most extreme forms of dissociation. It also picks up mild dissociation and more normal forms of dissociation. But what it doesn't do is look at the amnesia that's more found in dissociative amnesia, where people cannot recall all or part of a traumatic event or traumatic events or the events around that. And it doesn't look at the experience of intrusions that we've just been discussing that the MID-60 does so well. The DES is still an excellent instrument. So if you are suspecting that somebody has DID, then it is completely appropriate to be using the DES. If you are looking for a broad, you're thinking there's dissociation going on, but you're not really clear what it is, there seems to be a bit of depersonalization, there seems to be some kind of self-states maybe, but it's not that clear, then the MID-60 may give you a stronger picture of what's going on. I decided to include some information on the prevalence of what it is that we can expect to see within the general population. Dissociative disorders are a lot more common than people realise. Around 10% of people will have a dissociative disorder at some point in their life. The most common is actually dissociative amnesia, but it's not really diagnosed that often, and it's not often talked about. The research has really focused on dissociative identity disorder. So it's that really thin end of the triangle, the pointy end, where a lot of the focus is. And that can mean that subtler forms of dissociation, and not so subtle as well, can sometimes be missed. So we can see that even though depersonalization and derealization are very common symptoms, and they're often, even if people have a clinical level of it, that may be comorbid with another disorder, or they actually also then meet the criteria for something like other specified dissociative disorder, so they wouldn't be diagnosed with the depersonalization. Or it might be that they have post-traumatic stress disorder, so that's diagnosed instead. But it's a common symptom, just less common to be diagnosed as a standalone disorder. So the subclinical variant of DID, other specified dissociative disorder type 1, is a lot more common than DID. And that makes sense because people's experience with this are generally going to be less extreme. And that's why DID really sits at the top of the triangle, because the experiences that have created that fragmentation are so intense. They are so rare on the whole compared to the experiences that can cause, for example, dissociative amnesia, which can be a traumatic death of a loved one, seeing a suicide. It can even be natural disasters. It can be combat. It can be an assault. It can be a range of different experiences that are much more common in the general population. So we need to keep that in mind about what it is that we are looking for when we're searching for dissociation. It's not just the pointy end of the triangle. And within the MID-60, we also look at the somatoform symptoms, the conversion symptoms, conversion disorder. And these aren't seen so much as dissociation in North America and Australia, where I am from, but in Europe, conversion disorder is very much seen as part of dissociation, and it's the dissociation of the bodily experience, this compartmentalization of, for example, a sudden numbness in the arms when someone becomes angry, because their experience was if they lashed out, then the arms would go numb. So it's very much a dissociative experience. So they're not that common on their own, but we often see conversion symptoms within people with other dissociative disorders. So it's something to keep an eye out for. And now, since 2013, we've had the dissociative subtype of post-traumatic stress disorder, and 2% of the population will have that. So, and a lot of people will meet the criteria for both. For example, somebody could meet the criteria for dissociative amnesia and the dissociative subtype of PTSD, for example. But this is just to open your mind and also really think about what it is that MID-60 can do, because it's going to be focusing quite broadly. This slide just has notes for anyone that's interested in where I've got the data on prevalence from. So this slide really shows where the DES is focusing upon, and it is excellent, as I said, at picking up DID. There's a lot of questions on depersonalization within it, around a third of the questions, and you would think that would mean that it would be picked up if a person had depersonalization or derealization disorder, but that's not always the case, because often people use a cutoff score of 30 out of 100, which means the person is having these dissociative experiences that are described 30% of the time, which is a lot. And the person may well be having depersonalization that amount of the time, but when the score is taken as a whole, it is usually much lower. So that can be often missed when using the DES. The subclinical variant of DID, other specified dissociative disorder type 1, is picked up pretty well by the DES, around about 3/4 according to a study by Nielsen. So it does a fairly good job, but it is missing out on some of that. And as we said, dissociative amnesia, the majority of cases, and this was this study by Nielsen, and she found that it was really rare to pick up dissociative amnesia using the DES. And the DES also looks at a lot of normal dissociation. So there's a little band in the middle that the DES isn't detecting quite so much. It doesn't really have its feelers out in that part of the triangle. So it's really the higher range and the lower range. By comparison, when we look at the MID-60 and the MID, it's looking at this broad range of experiences. It focuses very generally on all of the aspects of dissociation, as well as looking at those conversion symptoms and flashbacks as well. And some more general experiences that are common to people with PTSD and dissociation, for example, trance and self-confusion. The MID-60 is a self-report instrument. So this means that the client reads and interprets the question themselves and decides how dissociative they are on that item. It's not a collaborative approach, but it is okay to provide some level of support and guidance for clients that need that, but they ultimately need to determine what their experience is. They should set aside 15 to 20 minutes to complete it. And there is a hard copy version that's available, but the best way, if it suits you, is to do it in an Excel spreadsheet, which has been set up for that purpose. It's very clear in answering question and response, and that enables you just to cut and paste the 60 items and the scores for the 60 items into the template. And that can also save on errors in transcription that are quite easy enough to do that could throw things out. And the scoring template that will automatically calculate the results for you. There are written instructions, and these have been developed by Michael Coy for the MID, for the full MID, and I have adapted these so they make sense for the MID-60. I also encourage clients to have a trusted person with them, because there are questions that can be confronting still, or even talking about their level of dissociation could be a little destabilizing. So if they are completing it out of the therapy session, it's good that either you know that they're doing it and support has been arranged, and or if you know that they have a support person that will be present during the time they're likely to be completing it. So if you see that your client has a score of 35, you can suspect they're pretty dissociative. And you'd look at this and go, well, it looks like they've got a dissociative disorder, and then you could look further into it. Is this a subclinical variant of DID? Is it DID? And also there's likely to be PTSD there as well. So this is a guide, it's not prescriptive. Unlike the MID, which is diagnostic, this is a screening tool. But what we do know is in normal populations, people do have dissociative experiences, but they're probably going to be scoring in the range around 11. In university populations using the DES, we know with like nearly 28,000 people that university students are spending nearly 17% of their time dissociating. So it's nothing to be alarmed about when people are being dissociative for this amount of the time, even though you may think, gosh, this person, I didn't realize they were so dissociative, but it's not to concern yourself with that too much until they're really getting over the score of 21. It is possible in that range of 15 to 20 that there is a more mild dissociative disorder happening. Once you get into the range above 64, it's something to be considering, is this a legitimate score, or is something else coming into play? So, I mean, it could be incredibly dissociative, somebody with DID that has the full spectrum of dissociative experiences and symptoms, but perhaps you'll also find that there might be a little bit of, somebody might be a bit neurotic or attention seeking, there could be some malingering or even psychosis. So it's at a point where you need to check for those things. And also, if you suspect somebody is incredibly dissociative and they're scoring 0, then that would be cause for concern too, when we remember that even people in the general population or people that aren't in clinical settings, people are still having dissociative experiences. They are common. It's a common thing to happen. So if someone's scoring 0, then I would be also raising my eyebrows if in therapy sessions they seem to be displaying dissociative symptoms. The next thing you would check is the subscales, because the subscales relate to particular dissociative disorders. Some of them are more broad, but for example, amnesia, the amnesia subscale is specific to dissociative identity disorder. And these experiences aren't particularly common at all in the general population. So the clinical cutoff is 10% of the time. So if somebody's having these amnestic experiences, they're waking up in a place and they have no idea how they got there and it's not drugs and alcohol, then that's something to be concerned about if the experience is 10%, which would be them saying it's not never, it's more than never, would be the equivalent in the way that it's scored. And some of them could be either subclinical DID or DID. So when you're looking at the people having this awareness of having other self states, and you can look at those. So if there's general self state intrusions happening, also if there's angry or persecutory intrusions. Then there's a subscale specifically for depersonalization and derealization. And for dissociative amnesia, there's quite a bit about just general distress about memory problems and loss of autobiographical memory. So for PTSD, you want to be looking at the flashback subscale, particularly if you think, well, is this person got a dissociative subtype of PTSD, you would be expecting that the depersonalization and PTSD, those two aspects would be meeting the clinical cutoff scores. So the person would therefore be having flashbacks more than 16% of the time. And I didn't determine what is clinically significant. That was done by Paul Dell when he developed the Multidimensional Inventory of Dissociation. So I have used his scoring and his insights in identifying what they would be, what the equivalence would be within the MID-60. There's also some general symptoms, and when we look at trance and self-confusion, they add to the picture. So we would expect that people that are very dissociative would be experiencing problematic symptoms of trance, as well as having a sense of profound self-confusion about themselves. And conversion disorder as well is one that we can look at. So even if they're not getting that overall clinical cutoff, you might actually identify this person's having psychogenic seizures, they're having, issues around losing sight or paralysis. So that would also be picked up as well. So this is something that even if the overall score isn't demonstrating that that person has a dissociative disorder, you could look further at it, because a person, as I was saying before, with the example of the dissociative subtype of PTSD, they may not score in a clinical range overall, but the relevant subscales would be, the clinical cutoffs would be met. So this gives you, it's not prescriptive, but it gives you the tools and ability and insight to look at what it is this person is experiencing and explore that further. And when we're looking at the clinical cutoffs, that is apparent because when you enter the scores or cut and paste them in, the ones that are clinically significant for each of the 60 items will turn pink if the individual item is above the clinical cutoff. So again, somebody might not meet the clinical cutoff overall for looking like they have a dissociative disorder, but they may have some problematic symptoms and you can work with those. So it can be really helpful in that way. It might be that the person's not particularly dissociative, but what you are seeing is, this profound self-confusion. Or, it could be that it looks like the person is experiencing amnesia, but they're not experiencing other aspects of dissociation. So it's really useful to look at the individual items as well. And the subscales also turn pink. So you'll see that the subscales that are elevated will be pink. So it's quite easy. You can just, when you're looking at the results, you can just check your Excel file and just see which ones are pink and then refer to them. And within your therapy session, you can also talk about some of those experiences, particularly the ones that are really high, and really focus on those if the person's ready to do that kind of processing. I will be posting the materials on my ResearchGate profile, so these can be downloaded. So within this, there's the advice to respondents about how they can complete the MID-60, and then we've got all of the questionnaires and scoring templates. So that will be available for you there.
And if you have feedback on how it's going for you in your clinical practice or need some tips for using it in your research, we'll leave my email address so you can get in touch.